Assalamu alaikum wa rahmatullahi wa barakatuh, dear colleagues and friends. Welcome back to our weekly presentations about one of the topics that we are facing in every day practice and that may come in the exam as one of the station. Today, our topic is about maternal collapse. And maternal collapse is the extreme emergency or the highest emergency in obstetric practice. And the collapse in general is the most critical emergency in any specialty. So today we are going to discuss all the points around the maternal collapse in clinical practice and in the exam. So what's maternal collapse? Maternal collapse is any acute event that may affect the cardiopulmonary system or the central nervous system, and it will result in reduced or absent conscious level. And it may result into cardiac arrest or even death. To say it is maternal, it has to occur at any time during pregnancy and up to 6 weeks postpartum. So this is the definition of maternal collapse. How we will face the situation in the exam? It will be as a structured discussion as it came before in the exam. You will be an ST5 working in the labor ward, and you have seen one patient who fall down on the floor, and the examiner or your consultant will ask you a few questions to how to manage a pregnant lady in collapse. So the first question, how you will do immediately, what's your immediate action, and whom you are going to call for help. You will mention the causes of the maternal collapse and what are the steps of CPR in a pregnant lady, and what are the adjustments that you will do for a pregnant lady during CPR, when and how you will do the perimortem cesarean section, what are the medications and the doses of drugs that can be given during the CPR, and what are the alternative if you fail to gain an IV access, and the role of defibrillation in a pregnant lady. So the first question, what are the causes of maternal collapse? In this diagram, actually you can have all the causes of maternal collapse, but to be specifically in pregnancy, just remember the abbreviation of the THE. We have 4 H's and 4 T's and E. The 4 H's include hypovolemia, which is mainly due to bleeding or hemorrhage, hypoxia, which may result from a cardiac event like peripartum cardiomyopathy, or it may result from aortic dissection. Hypo and hyperkalemia and hyponatremia mainly results from the use of oxytocin during pregnancy, and hypothermia, which is no more likely a cause of collapse now. These are the 4 H's. Then coming to the 4 T's, including the thromboembolism. The thromboembolism may be pulmonary or amniotic fluid embolism. Toxicity, the most common causes of toxicity in obstetric practice is magnesium sulfate toxicity and the toxicity of local anesthetic drugs. Also, tension, pneumothorax, and cardiac tamponade, which results mainly following trauma or suicide attempts. So the 4 H's and the 4 T's, then the E for eclampsia and preeclampsia, including the intracranial hemorrhage. So still, hemorrhage is the most common cause of maternal collapse, especially in the developing countries. So this is the answer of the first question. These are the reversible causes of maternal collapse. Just remember the abbreviation of the 4 H's, 4 T's, and E for eclampsia and preeclampsia. Second question, what are the differences between resuscitation in pregnant and non-pregnant ladies? The differences here, it results from the physiological changes which occur in pregnancy and may affect the process of resuscitation. There is a large table here that you will find in the RCOG guideline. To make it easier, we will put it here from the head to the toe and mentioning how you can adjust your performance during the CPR to adjust the changes or the physiological changes that occur in pregnancy. First, there will be breast enlargement and laryngeal edema. So these ladies will be at risk of aspiration at risk of difficult intubation, at risk of hypoxia. So early secure of the airway is very important in a pregnant lady. So during the CPR of a pregnant lady, secure the airway early to avoid these physiological changes. The second, especially in pregnant lady who is more than 20 weeks, there is aortocaval compression. This aortocaval compression by the pregnant uterus, especially in supine position, will result in reduced the venous return and the cardiac output by almost 30 to 40%. So how to adjust your performance during the CPR? Uterine displacement. How to do uterine displacement? Either by manual displacement of the uterus to the left side or by left lateral tilt of 15 to 30 degrees if CPR is not required. So this is the second change, which is aortocaval compression and how to adjust your performance during the CPR. Next, there is increase in the uterine blood flow. 10% of the circulation of the circulating blood will go to the uterus. This will lead to more predisposition of hemorrhage and hypovolemia. So this lady needs aggressive fluid resuscitation, but with a special precaution in patients with preeclampsia and eclampsia. The best way to avoid this is to empty the uterus early, to do perimortem cesarean section, because this will increase the circulating blood volume and will reduce the oxygen consumption by the baby and by the uterus and will improve the results of resuscitation. The next physiological change, there will be physiological dilution or dilutional anemia, which reduces the oxygen carrying capacity, and it will reduce the oxygen and it will increase the oxygen consumption. So how to avoid this effect? By early and high rate of oxygen flow. You will give oxygen at a rate of 10 to 15 liters per minute, and it will be 100% oxygen. So these are the physiological changes that occur in the pregnancy and affect resuscitation, and how to adjust your resuscitation in a pregnant lady to accommodate or to avoid the effects of these physiological changes. Now coming to the core of this station, which is how to do resuscitation in a pregnant lady. You will follow the same steps of resuscitation of any adult. So the first step in resuscitation is to ensure the safety of the scene, to avoid harm of the resuscitator. We don't need, instead of one victim, we don't need two victims to be there. So once the safety of the scene is ensured, check the response of the patient, tap the shoulder of the patient and shout, hello, hello, are you okay? Are you okay? If the patient is responding or not responding. If the patient is not responding, in this case, call for help. Here comes the question, whom you are going to call for help? The answer here will be, it depends, as usual, it depends. So if you are in the street, you will call the emergency response system, which is ambulance. If you are in a maternity unit, this will depend on the kind of the maternity unit. You are a part of general hospital, or you are in a stand-alone consultant-led maternity unit. If you are a part of general hospital, there will be a hospital cardiopulmonary arrest team. So in addition to the hospital cardiopulmonary arrest team for resuscitation of a lady which is pregnant, we will add senior midwife, senior resident obstetrician, senior resident anesthetist, and the neonatal team if she is more than 22 weeks. So this is the case if you are in a maternity unit which is part of a general hospital. If you are in a stand-alone consultant-led maternity unit, so there is no hospital cardiopulmonary arrest team. So the team here will be composed of senior midwife and operating department practitioners, resident obstetric staff, and resident obstetric anesthetist. So those are the people that you are going to call in case of maternal collapse. It will depend if you are in the street, or if you are in a general hospital, or if you are in a stand-alone consultant-led maternity unit. So ensure the safety of the scene, check the response of the patient, then call for help, and now the next step will be checking for pulse and breathing. Don't move the patient, please, especially if you are suspecting that there is a spinal injury. So feel for the carotid pulse and look, listen, and feel for breathing. Look, listen, and feel for breathing. Maximum for 5 to 10 seconds. 5 to 10 seconds is the maximum time you have to check. If the patient is responsive or not responsive, then you will continue your management. The missed part of most of the candidates during the station is if the patient is responsive. Sometimes the patient falls, but when you are checking her response, the patient is responsive and she is breathing. So there is no CPR needed in this case. No CPR needed if the patient is breathing and is responsive. All what you need in this case is high flow oxygen, 100% oxygen, 10 to 15 liters per minute. Then you will call for help from the internal medicine or from the intensivist or from the anesthetist to come and to continue observation. So if the patient is responsive and she's breathing, in this case, we need to do full assessment of the patient. The full assessment here include primary assessment and secondary assessment. Primary assessment following the A, B, C, D, E approach, and secondary assessment, remember the abbreviation of sample. Let's come first to the primary assessment. Primary assessment, A for airway. The airway has to be maintained patent, and this is a priority. For the breathing, effective breathing is essential. The circulation, you have to maintain adequate oxygenation. For the disability, remember the abbreviation again, A, V, B, U. A, if the patient is alert, you are here assessing the mental capacity of the patient, the mental state of the patient. A means alert, so she will take Glasgow score of 15. V means the patient is responding to verbal stimulation, so the Glasgow score will be 13. B for pain stimulation, the score will be 8. And U means the patient is unresponsive and the score will be less than 6. If the score is less than 8, this is an indication of intubation. So this is the disability or the level of consciousness of the patient. Then the environment and the exposure, you have to expose the patient, see if there is any concerns in or around the patient's body, if there is any possibility of any harm, if there is any possibility that the patient may have, for example, internal hemorrhage, the patient checks the cesarean or the scar of the operation. This is the meaning of exposure. So this is a primary assessment, A, B, C, D, and E. The secondary assessment, remember the abbreviation of sample. So S for the signs. So you have to check the pulse, the blood pressure, the oxygen saturation, the respiratory rate, the temperature, all the vital signs of the patient. Then A for allergy, you have to check if the patient has any form of allergy because the patient may be in anaphylactic reaction. M for medication, if the patient is taking any medication, for example, anti-epileptics or anti-diabetic drugs. B for past medical history, if the patient has any cardiac issues, for example. L for the last meal, because these patients are at high risk of aspiration. Then E for, again, for the environment and the circumstances around the event. So this is the answer. If the patient is responsive, what you will do, you will give, no CPR is needed. The patient will need oxygen 100% at a rate of 10 to 15 liters per minute. Then we will do primary assessment, airway, breathing, circulation, disability, and exposure and environment. Then the secondary assessment will be sample, S for signs, A for allergy, M for the medication, P for the past medical history, L for the last meal, and E for the environment or the event. Now coming to the second point, which most of you are going directly without mentioning the patient who's unresponsive, who's responsive. Now, if the patient has no response and there is no pulse or breathing, this patient now is in real collapse. So what you are going to do, follow the steps of resuscitation as in the resuscitation program. In the resuscitation, any adult or child resuscitation, you will go through the ABC approach. ABC approach. Now, you can even go for C at the beginning. Now, the new recommendation is to go for C. C means the circulation, then A for the airway, then B for breathing. A for airway. So again, the airway has to be kept patent. and early intubation. Consider early intubation in a pregnant lady because these ladies are at high risk of difficult intubation. So recourse for early intubation. P for breathing. You have to give supplemental oxygen as soon as possible. Start with bag and mask. If the patient needs intubation, it has to be done by an experienced anesthetist and give oxygen, 100% oxygen at a rate of 10 to 15 liters per minute. So this is for A and B. C, we will go for three important parts in the C. Remember the chest compression, abdominal ultrasound scan, wide bore cannulas, and the perimortem cesarean section. These are the 4 points in the C or the circulation. Starting by the chest compression. First, you have to put the patient in left lateral tilt on a firm surface, or you can use this switch. It's called the cardiac wedge, especially in patients who are more than 20 weeks. Why to put the patient in 15 to 30 degrees? To avoid the compression in the aorta and inferior vena cava. Aortocaval compression will reduce the venous return and the cardiac output by around 30 to 40%. So the relief of these compressions will improve the result of resuscitation. Once, how you will go? You will go for at a rate of 30 compressions and 2 ventilation if you are using the bag and mask. 30 compression and 2 ventilation. Once intubation is performed, you will go for continuous compression at a rate of 100 to 120 compression, and you will give 10 ventilations per minute. So the rate of chest compression to ventilation before intubation will be 30 compression to 2 ventilation. After intubation, it will be 100 to 120 compression and 10 ventilation breathe. After chest compression, during the process of CPR, all the time we are thinking about the possible causes. So one of the possible causes in pregnant lady is bleeding. So an abdominal ultrasound has to be done by an experienced sonographer or radiologist to exclude the possibility of concealed hemorrhage. Wide bore cannulas has to be inserted as soon as possible, and it's better to be above the level of the diaphragm to avoid the effect of aortocaval compression. So the minimum 16 gauge has to be inserted as soon as possible and start fluid management. The fluid management will depend on the cause. So again, during the process of resuscitation, all the time during the process, you are thinking about the possible differential diagnosis. One of the common causes of maternal collapse, as we said before, is maternal hemorrhage. So if there is hemorrhage, aggressive approach or massive transfusion protocol. If there is any other reasons, so you have to take care during your approach, especially in cases of preeclampsia and eclampsia. We know that the rate of infusion will be 8 ml per kg per hour. Now, if you find a difficulty in inserting the cannulas, if you find the difficulty to find a peripheral line because it was delayed, so what are the alternatives? And this is another question. What are the alternatives to the peripheral venous access? The alternatives include central venous line, interosseous route, or you may need to do venous cut down to insert an alternative airline to start your fluid management. To help in resuscitation, especially in ladies who are pregnant more than 20 weeks, perimortem cesarean section should be performed. You will start doing the perimortem cesarean section within 4 minutes of maternal collapse if the gestational age is more than 20 weeks. So you will start within 4 minutes, and the baby has to be delivered within 5 minutes of collapse. Why 4 to 5 minutes? Because irreversible brain damage occurs within 5 to 6 minutes of the collapse. And here we are talking about the mother, because the perimortem cesarean section is mainly done for maternal interest. It is not done for the baby. Yes, if the baby is viable, it may help to save the baby, but the perimortem cesarean section, it is done mainly for the maternal interest, not for the baby. Why we are doing perimortem cesarean section? Because the aortocaval compression is reducing the venous return and the cardiac output. Delivery of the baby
will help to decrease the oxygen consumption and increase the venous return and the cardiac output, and it will facilitate resuscitation. Where to do the perimortem cesarean section? Don't waste time in transferring the patient from the site of collapse to the theater. Do the cesarean at the place of resuscitation. All what you need here, you need a scalpel, fixed scalpel, and 2 cord clamps. Don't be worried from the bleeding because there is no circulation and the blood loss here will be minimal. Which incision is recommended? The best incision in the perimortem cesarean section is to do midline longitudinal incision in the skin and in the uterus. But because most obstetricians are not familiar with the midline incision, you can go for transverse incision or whatsoever the incision they are familiar, and the incision to facilitate rapid access to the baby. But the recommendation, the midline abdominal and the classic uterine incision may be better. Once resuscitation is successful, now you can transfer the woman to a suitable place, which is the operating theater, to continue the procedure. What is the role of defibrillation? Defibrillation now, the recommendation of the American Heart Association, defibrillation is the most important. Once the AED, which is the more automated external defibrillator, is available, attach it to the patient and check the rhythm and give shock or no. The same defibrillation settings are used for pregnant and non-pregnant ladies. There is no worries. There is no effect on the fetus. So it is very important. No change. The dose or the shock will be given at a rate of 150 to 360 joules. It can be given as monophasic or biphasic. The adhesive pad, the right one will be put on the same place, but the left one will be put lateral to the left breast. Why lateral to the left breast? Because of the splitting of the diaphragm, because the heart is moved up and to the left, you will put the adhesive pad to the left side, to lateral to the left breast. The breast size is increased, the heart is pushed upwards and laterally, so the left pad will be attached lateral to the left breast. Adhesive pads are better in a pregnant lady than the defibrillator paddles. So the adhesive pads are preferable here. Once it's attached, please clear, stop the CPR and check for the rhythm. It will automatically check for the rhythm. We have 2 possibilities here, either shockable or non-shockable rhythm. The shockable rhythm including VF, which is ventricular fibrillation, or pulseless VTAC, which is ventricular tachycardia. So this shockable rhythm will need shock. So once the machine detects that the patient is in shockable rhythm and needs shock, you will clear, everyone has to be away, remove the CTG monitors and give the shock. Once the shock is delivered, again continue CPR for 2 minutes, then reassess for the shock, for the rhythm again. If the patient has non-shockable rhythm, continue the CPR. So again, there is no changes in the fibrillation setting. There is no changes in the dose of the defibrillator and monophasic or biphasic, but adhesive pads are preferable than the pedals. The left pad has to be attached lateral to the left breast. It works automatically. If you have shockable rhythm, you will clear, remove the CTG monitors, give shock and continue CPR. If it is non-shockable rhythm in asystole or pulseless electric activity, you will continue CPR without giving shock for 2 minutes. Then after 2 minutes, you will continue the CPR again. What are the drugs that can be used in resuscitation? Simply or generally, no alteration in the algorithm of the drugs or its doses. You can use all the drugs. You can use the same doses for pregnant and non-pregnant ladies. All the drugs you can use: adrenaline, you can use lidocaine, atropine, even amiodarone. There are some concerns about the amiodarone, but if you can see here during the algorithm or the diagram for resuscitation, the amiodarone will be given after 4 minutes. And after 4 minutes, the baby has to be already delivered by perimortem cesarean section if the patient is still not responding. So even the concerns of amiodarone are not valid here. So all the drugs can be given. What are the drugs that are important? Of course, the most important drug is adrenaline. For the general steps of resuscitation, you will give the epinephrine, and it can be given every 3 to 5 minutes. It can be given every 3 to 5 minutes. The dose, general dose during resuscitation will be 0.01 milligram per kilogram. And as I said, can be repeated every 3 to 5 minutes during the CPR. If the patient is in anaphylaxis, you will give 500 microgram or 0.5 ml. The concentration here will be 1 in 1,000, and it's given intramuscular. And it can be repeated after 3 to 5 minutes. Here we are talking about the anaphylaxis, please. If inexperienced hands, the adrenaline can be given IV, and the dose here will be 50 microgram or 0.5 ml of 1 in 10,000 solution. So the IV solution will be more diluted. It will be 1 in 10,000 solution, but IM can be given 1 in 1,000 solution. The IV, it has to be given by experienced hands. In case of anaphylaxis, you can give some adjuvant therapy like chlorpheniramine, 10 milligram, and hydrocortisone, 200 milligram. The common mistake here in the exam, what is the dose of adrenaline? All the candidates are going directly to the dose of anaphylaxis, and they forget the dose for the general resuscitation. So the first drug to be given is adrenaline. Lidocaine can be given at a dose of 1 milligram per kilogram. Amiodarone again can be given for maternal interest. By the time it's needed, the baby will be delivered. Intralipid. Intralipid is very important to be available in any resuscitation set or any crash cart. Intralipid has to be there. Intralipid is given in cases of local anesthetic toxicity. And if you will give intralipid, it has to be reported to the NHS improvement and the lipid rescue site. The dose of intralipid, 1.5 ml per kg over 1 minute as a loading dose, then 15 ml per kg per hour as a maintenance dose. So this is regarding the intralipid. The next drug is calcium gluconate. We all know about the toxicity of magnesium sulfate given in cases of preeclampsia. So the antidote is calcium gluconate, 10 ml, 10% solution, can be given slowly IV over 10 minutes. So the rule of 10 ml, 10% solution given slowly over 10 minutes. So this is the algorithm for collapse. You have to check the safety of the scene, then stimulate the patient and check for the response. If there is a response, what you are going to do, primary assessment and secondary assessment, and give the patient 100% oxygen at a rate of 10 to 15 liters per minute. If the patient is not responsive, you will go through the steps of the CPR, A, B, C, A for airway, B for breathing, and C for the circulation. The circulation means the CPR, means ultrasound, means 2 wide bore cannulas, and means perimortem cesarean section if needed. For how long you will continue the resuscitation efforts? Until a decision will be taken by consultant obstetrician and consultant anesthetist to discontinue the resuscitation effort. This consideration has to be conjoined with the cardiac arrest team. Usually, the outcome is over 50%. There is maternal survival rates of over 50% have been reported. You will evaluate the condition after finishing the resuscitation. If the patient is alive or if the patient is dead. If the patient is alive, you will continue observation. HDU, intensivist, you will continue observation, use chart, air, way, breathing, circulation, urine fluid intake and output, vital signs, and to treat the possible cause. If the patient died, we have to inform the coroner and we have to record it in the MRCOG. Okay, then the 7 Ds for clinical governances. Please don't forget this during the discussion. The documentation, proper documentation, debriefing of the patient and of the staff, statics or incident reporting, then duty of candor for the patient and her family, discussion and audits, root cause analysis, and reflective practice, and the drills that are recommended that all people who are working in emergency or in obstetric practice to have drills and how to do resuscitation in cases of maternal collapse annually. So this is the station, how to answer the questions and how to do it in your real life. This video will be the conclusion of our station. It will give us a review of the discussion. Hope you will benefit from it. So what's maternal collapse again? Is any acute event that involves the cardiopulmonary system or the central nervous system. It results in absent conscious level or even cardiac arrest or death at any stage of pregnancy and up to 6 weeks postpartum. The causes of maternal collapse, again, this diagram can give you an idea about it, but to be more specific, remember that the reversible causes including 4H's, 4T's, and eclampsia and preeclampsia. Hypovolemia, mainly from hemorrhage. Hypoxia, mainly from cardiac causes, like cardiomyopathy or aortic dissection. Then hypo and hyperkalemia and hyponatremia, mainly from oxytocin use. Hypothermia, which is no more likely nowadays. Coming to the next 4T's, thromboembolism, which may be pulmonary or amniotic fluid embolism, toxicity from magnesium sulfate or from local anesthetics, then tension pneumothorax and cardiac tamponade from trauma and from suicide attempts. And please don't forget the eclampsia and preeclampsia and intracranial hemorrhage. What you will do? The management of maternal collapse. Safe environment, scene is safe, stimulate the patient and assess her response. If the patient is not responding, call for help. And now we know whom to call for help, the resuscitation team and what's included in the resuscitation team. The principles of management, A, B, C, D, and E. A for airway, maintain patent airway, which may be closed because this patient has some physiological changes. Maintain the patent airway. Keep the patient in left lateral tilt. Use the wedge to relieve the aortocaval compression. If no aortocaval compression, there will be no supine hypotension and there will be increase in the cardiac output and the venous return, which were reduced by this compression. Left lateral tilt by wedge, or you can use bellows or even your knees behind the back of the patient. How to maintain the airway patent? By suctioning and by the triple maneuver. Triple maneuver, head tilt, chin lift, and jaw thrust. Avoid the head tilt if there is any possibility of cervical injury. So in this case, use oropharyngeal tube or endotracheal intubation. Now, breathing. Look, listen, and feel for the breathing. Then, for how long? Maximum 5 to 10 seconds. If present, give high flow oxygen. If absent, start the CPR. How you start the CPR? 30 compressions at a rate of 100 to 120 per minute. The depth will be 5 to 6 cm and 2 compression. So it will be 30 compression to 2 ventilation. Now the circulation. The circulation, you have to check the pulse and the blood pressure. You have to insert 2 wide bore cannulas, 16 gauge needle, and manage the hypovolemia, start fluid resuscitation. If there is absent breathing and absent circulation, in this case, you will continue the CPR. This is how to go step by step. Now, D for disability. Disability is the level of conscious. A for alert. It will take by Glasgow score 15, verbal 13, pain stimulus 8, and unresponsive 6. If the Glasgow score less than 8, you need intubation. Again, intubation by an experienced person to avoid hypoxia. E for exposure. Exposure. Here we have to monitor the patient. We have to search for any concerns. The blood pressure, pulse oximeter, and ECG, end-tidal CO2, and the respiratory rate, and you may consider putting a catheter to check the input and output. During resuscitation, consider the differential diagnosis, manage any reversible cause, and assess for fetal well-being. Don't forget the baby, put the CTG. But the mother is a priority, always priority. Assess and review the vital signs and investigate and plan for management and ask for help from other specialties. Again, the physiological changes during a pregnant lady. There is decrease in the oxygen capacity. There is decrease in the cardiac output and the venous return. There is increase in the oxygen consumption. There is increased the possibility of aspiration because of the reduced gastric motility and increased weight of the breast. So thank you so much. Hope this was helpful. This covers all the questions in the station. Please, if you find it helpful, remember me in your prayers and share it with your friends. Thank you so much and see you next week, inshallah. Wassalamu alaikum wa rahmatullahi wa barakatuh.